talk on this hot topic. I think it's quite a dry hot topic, but I'll try and give you some data. So, really, this is the role of adjunctive medication when you're doing a surgical AF procedure. We want to optimize our sinus rhythm rate, we want to prevent thromboembolism, and we want to minimize the risks. I think heart block and pacing is an adverse event, not the end of the world, but adverse. Of course, we don't want unnecessary bleeding risk. There are now some guidelines, and there's quite a lot of them. So 2014, the AHA and American College gave us theirs, ESC a couple of years later, and then in 2017, there were surgical guidelines from the SCTS, and the Heart Rhythm Society, with everybody else, gave us their view as well. Unfortunately, in the place of medication, their views are very limited, but I'll tell you what they have. Allow me to show you one of the guys who taught me on pharmacology. This is Professor Vaughan Williams. And as you know, he categorized the antiarrhythmics. And in AF, we're looking at the class 1, the sodium channel blockers, mainly flecainide, maybe propafenone. I have to say I have not used those myself. And the class 3 drugs, amiodarone and sotalol. And you'll all know that sotalol has a beta blocking effect also. Here's what the guidelines have to say. So the 2017 guidelines from the HRS, in the place of catheter ablation, they suggest prophylactic antiarrhythmic drugs to prevent recurrent AF in the early period. But in the longer term, all they can say is that the role of antiarrhythmic drugs is unclear. Similarly, the SCTS recommend that for the first 2 or 3 months you use class 1 or class 3 drugs, provided they're tolerated. The European guidelines, 2016, this is catheter ablation. They're suggesting 2 to 3 months of amiodarone or flecainide. And the AHA did not give specific comment. So the evidence, such as it is, and of course it's limited, which is why the guidelines are quite vague. There's a 5A study from 2011. This is catheter-based PVI for paroxysmal AF in 100 patients. And they randomized them to have an antiarrhythmic or not in the early period. This reduced the early recurrence rate, but at 6 months and beyond, there was no significant difference in their rhythm. AmioCat was another catheter-based study looking at, again, early amiodarone versus placebo. And the amiodarone group had less cardioversion, less readmission, but there was no real difference in atrial tachycardias. Nivad's group have done a lot of work here. They have done a randomized trial of amiodarone versus placebo in surgical ablation. And they found that, as we would hope, amiodarone does reduce the risk of early recurrence, cardioversion, or need for crossover, a 50% reduction in the early period. But it must be mentioned that more than a third of these patients, the amiodarone had to be discontinued for contraindications or interactions. I think the most helpful data we have in this area comes from Virginia, from Nivad. And they've developed a protocol which I'll gloss over because it's quite detailed, published in 2010, so it's been there a while. They give patients amiodarone or sotalol for the first 3 months. And at that stage, if on ECG or Holter, the patient is in sinus, they stop the drugs. Another 1 to 3 months later, the patients have a prolonged Holter, and provided this shows sinus rhythm and the appendage has been dealt with, they consider stopping anticoagulation. On the other hand, if at early follow-up the patient has atrial fibrillation, then they adopt for cardioversion and consider a different antiarrhythmic drug. And they go through cycles of this every 3 months in the first year. And they would only consider giving up on rhythm control after 3 cardioversions and several drugs. And the paper gives us a very nice flowchart, which I won't drag you through now, but basically it's cycles of rhythm check, antiarrhythmic, plus or minus cardioversion. And the results are interesting. So they're looking at nearly 400 patients in their institution, and this is multiple surgeons, so different strategies. Those following the algorithm have 200 amiodarone BD for a week, and then once daily for 3 months, using sotalol or flecainide if there's a contraindication. And that group has been compared with the overall group, and these are impressive results anyway at 12 and 24 months, but the algorithm does seem to optimize the rate of sinus rhythm. I took a moment to look at the downside of antiarrhythmic drugs. To my mind, one of the problems when the patient's in the perioperative period is if we give them heart block or they're profoundly bradycardic and they require a pacemaker, I think that's a negative outcome. And I looked at the rates of pacemaker that have been published, and we've seen one of these figures already, which we think is a bit of an outlier. But certainly rates of 5 to 10% would not be a surprise. And in Sam Nesheff's AMAZE trial, both the AF group and the control group had over a 10% pacing rate. And this could be partly the effect of the maze itself. It could be unmasking sinus node disease when treating AF. So that's half of it. Anticoagulation. This goes back to the beginning of last century, where they found that some cattle had a bleeding disorder if they ate spoiled hay. And then in Wisconsin, this is important, Carl Link studied this and found that the chemical responsible in the hay was dicumarol. And he further demonstrated this was produced by breakdown of coumarin, not coumadin, but coumarin, which is the chemical which gives cut grass its smell. Anyway, he was funded by the Wisconsin Alumni Research Foundation, and that's why we have warfarin. In terms of anticoagulation, there are a few issues. There are some guidelines, and I think it's important to distinguish between early and long-term anticoagulation. And then the evidence we want is, what's the stroke risk after you've dealt with the appendage? What's the stroke risk after a maze and closure of the appendage? And what's the bleeding risk? And my thanks to HQ for the pictures. That's a disclosure. So the guidelines. The HRS suggest minimum 2 months of anticoagulation. And beyond that, in the surgical patient, they recommend a patient-by-patient decision. They do emphasize that you should look for adequate closure of the appendage. The STS, this is surgical only, they suggest anticoagulation until the patient is in stable sinus off all drugs. And in their criteria, you want a halter for at least 24 hours, and the only echo criterion is the absence of smoke in the left atrium. The other guidelines really only comment on catheter ablation. So the Europeans anticoagulate for at least 8 weeks, and then as per AF guidelines, which usually means continue. And the AHA, very, very similar. Now, early post-procedure, it's different. The patients are in a prothrombotic condition, and we've deliberately created multiple sites of endothelial injury in the atria. So it's a no-brainer, and the evidence supports that. Now, if you've closed the left atrial appendage, I think Dr. Gillenov mentioned the Watchman data. There were a couple of Watchman trials, and these have been taken very positively. And basically, if it were not for the procedural risks, device closure of the appendage by a Watchman is equivalent to anticoagulation in stroke prevention. The simplistic surgical techniques of ligating or over-sewing the appendage are a disaster. Basically, they're not recommended. There is certainly one device with high level of success. We don't have any quality evidence yet on the outcomes, but I believe that will be available soon. Those of you who've been involved in LAS3 know that that's closed, and I certainly hope that will give the answer to that question. So anticoagulation after maze, there are a few studies, and the results are interesting. So NIVAD has looked at 700 patients who had a maze with a closure of the appendage, and the stroke or TIA rate was only 5 per 1,000 patient years. The bleeding rate was 3 times that. And importantly, when they looked at this, I think you've already shown this data, Dr. Gillenov, the stroke risk was not related to a CHA2DS2-VASc over 2. The Montreal group looked at 100 patients, and half of these had already stopped their warfarin at 3 months. There were 2 strokes only, and both of those were anticoagulated. There were 5 episodes of bleeding in the early period. NIVAD subsequently looked at his isolated, minimally invasive maze, 130 patients, 80% discontinued the drugs, 80% were not anticoagulated, and there was 1 stroke. From Damiano's group, long follow-up of 400 patients. Most patients were stopping the anticoagulants. There were 6 neurological events, so less than 1% per year. And again, stroke did not appear to be associated with the CHA2DS2-VASc score or with the presence or absence of anticoagulation. And the predictors were, as you might expect, previous stroke, but also diabetes. And then from South Korea, 300 patients over 5 years having concomitant maze. Warfarin was stopped at 6 months in many of these, and the thromboembolic rate was tiny. The late mortality rate, that might be thromboembolic, was also small. Just briefly, for those who are hesitating, I work in a fairly small unit. We do 900 cases a year. We've been ablating for 15 years now, and we do about 50 cases a year, and 20% of our mitral valves get a maze. We do a full Cox maze 4, we clip the appendage. And our policy for antiarrhythmics is to give amiodarone if they're in sinus rhythm, to consider cardioversion if they're in AF before discharge or at first follow-up. And up to now, we've mostly anticoagulated patients for the first year before monitoring by prolonged Holter and by echo. And we don't just look for smoke. I like to look at the echo and see an A wave, so we know we've got atrial contraction. We looked at our data over a 2-year period recently, and we've got an 80% sinus rhythm at 12 months, so it can be done without great difficulty. 1 stroke, 1 TIA, some pacemakers, and I'm not shy about sending the patients back to the EP guys if there's an issue. So, to conclude, it's possible to get good results with surgical AF ablation. I think we know that. The antiarrhythmic drugs do reduce the early recurrence of AF, and there is some evidence that aggressive use of antiarrhythmic drugs and cardioversion may optimize the absolute result. We know that we need anticoagulation in the early period, but longer term, the stroke risk after a maze, especially with closure of the appendage, is low. And so we should be considering discontinuing the anticoagulants in patients with sustained sinus rhythm. But there's an elephant in the room. We can only do this, certainly in the UK, with collaboration with our EP colleagues, and they don't know this data, and they think the patients all need anticoagulating with that bleeding risk we've seen. So I think I'm not the right audience here necessarily. Thank you.